Do you think while we do this that we should go ahead and play Bonnie's talk? Just so we could get set up? Do you think that would make sense? Okay, so we'll skip and we'll go ahead and let Bonnie start first, which truth is Bonnie should always start us off with everything. So Bonnie Sweenor is she's the endowed professor of disability health and justice and is the founding director of the Johns Hopkins Disability Health Research Center, which uses data-driven approaches to shift the paradigm from living with a disability to thriving with a disability. She really wanted to be here with us today to talk about inclusion of researchers who have sensory loss and sensory impairment in our work, but she was not able to join us because she was needed at the WHO. So she has recorded a talk for us. We're very lucky, and so we'll go ahead and play that. Thank you.
Good morning. I'm Bonnie Lynn Sweenor, Director of the Johns Hopkins Disability Health Research Center. And while I'm so sorry that I cannot be with you all in person today or even in real time, I'm so grateful to have this chance to present to you at this exciting conference. I want to first start by thanking the organizers of Sense Network and the Sense Network Conference, especially Jennifer Deal, Josh Ehrlich, Nick Reed, Jay Pinto, and Varshini Varadraj. Thank you for working so hard to organize this meeting. It's so amazing how far the network has come and how much it's grown since its beginning with just a small group of us in what I think was 2019. So today I'm going to talk about advancing research by removing barriers for people with disabilities. But that seems impossible to have a talk about at this moment in time without at least considering some history about where things started and where we are today on these topics. Many may know that I am a person with a disability. I have low vision, and my work in this area is not just professional, but also personal. On this slide, I'm showing a response that I once received from a grant reviewer, and it states, a researcher with a visual impairment is biased in conducting vision research. I'm shocked by how shocked I was by that statement at that time early in my career. I had so proudly disclosed my lived experience with vision loss in my grant application and discussed it as a positive attribute. But certainly, this reviewer had other viewpoints. And while we're all entitled to our own viewpoints, it is important to think about what such a statement means. That it's making a case that researchers without vision loss are somehow less biased or unbiased by the virtue of their absence of lived experience. And that's really at the heart of what I wanted to discuss today, the role and the value of lived experience in research. It's likely no surprise to many of you either that people with disabilities, including people with vision loss, those who are hard of hearing, who are blind, are deaf, face largely unaddressed barriers to being a part of research, either as a research participant or as a researcher themselves. On this slide, there's a quote from a qualitative research study that we conducted at my center about academic researchers with disabilities and their experience. This was led by Dr. Franz Castro, and this quote states, "It's ridiculous that I'm regularly the only disabled person in a room, group, etc., focused on the study of people with disabilities." This was a common theme in our study. It's been a common theme and issue among my disabled academic colleagues, among my students. It's certainly something that I have often faced. And early in my career, I really felt that feeling of being the only one with vision loss in so many of my research teams when I was doing vision research. It was lonely, it was isolating, and so I did the only thing that I really knew how to do, which was research. So working with Dr. Lisa Meeks, who at the time was at the University of Michigan, we examined the percentage of NIH principal investigators who reported having a disability and found that over 10 years, from 2008 to 2018, this estimate declined from 1.9% to 1.2%. That's far, far below the over 25% of American adults with disabilities. It's a clear sign that we have a problem. Dr. Meeks has also published many works about the representation or underrepresentation and barriers that medical students and healthcare providers with disabilities face. On this slide is a bar graph indicating that in 2016, only 2.7% of medical students reported having a disability. That increased to 4.6% in 2019. Clear progress, but far away from parity. In national data on the STEM workforce, we see a mirroring of those results. Data from the 2021 report on women, minorities, and persons with disabilities in science and engineering found that less than 3% of the US STEM, STEM workforce reports having a disability. Most striking is that this is the only group whose representation has gone unchanged, meaning no improvement in the past decade. So we've known about this issue for 10 years, but clearly we haven't done anything, or we're not doing anything that's working. For researchers with disabilities, there's many layers, many barriers to being part of the research enterprise, and it's unfortunately a cycle. In a paper also led by the amazing Lisa Meeks, we outlined how unconscious bias against disabled people in research settings leads to a lack of inclusive policies in those spaces. That results in barriers to education, reduced research and STEM career opportunities. That all results in lower representation, fewer role models with lived experience, and ultimately perpetuates ableist ideas and embeds systemic ableism across research setting. And this cycle goes on and on, representing it as a cyclical cycle on the slide. For many people with disabilities, research environments also lock us out because they're not accessible. For people with vision impairment or vision loss, for example, the inaccessibility of data in scientific journals is profound and too often ignored. I can personally attest to this. A recent paper highlights and reports that many life science resources contain severe accessibility issues. Almost 75% of life science data portals and 69% of journal websites examined in this study had severe accessibility issues. Although implementing basic accessibility standards can help our research reach broader audiences, even far beyond people with disabilities, accessibility still is deprioritized. It's treated as a pain, and it's not taught in research and science curricula. We're not teaching the next generation on how to do this better. Up to now, I've really discussed the barriers that disabled researchers face, but that's only part of the picture. We're also too often failing to include people with disabilities in our research itself. In a paper with Dr. Jennifer Deal, we outlined just this problem. We state, even when people with disabilities are enrolled in clinical trials, they're often excluded from data collection and analysis. The inclusion of people with disabilities is essential for clinical trial generalizability, yet we are so far behind in making sure that our recruitment, consent, and data collection practices actually give people with disabilities an opportunity to participate, making sure their exclusion is based on scientific reasoning and not inconvenience. My colleague Rupa Valdez at the University of Virginia has developed an excellent framework to help us think about where, when, and how disabled people can be included in research. The first step is about education and understanding, and I love that that's the first step. It's making sure that researchers really get to know the disability context, disability culture, get to know the population that you study and you serve, but not from your perspective, from the perspective of those that are part of that population. Partnerships are also essential, and that's not about box checking. Instead, it's about forging meaningful relationships that recognize and address the inherent power imbalances that come with those types of relationships. Dr. Valdez also emphasizes the need to make all study procedures accessible and culturally responsive. Importantly, she highlights that this is a cycle of a relationship of relationship building and trust building. Disability inclusive research should not be transactional. Instead, it should be thought about as a method to build foundations, build relationships, and increase the knowledge that we need to make our work and our science better. Over the past 5 years, momentum has certainly been building around disability inclusive research. A really important highlight was the NIH's designation of people with disabilities as a health disparity population in September 2023. That was a very long and very hard won fight that opened the door to research that had not previously been possible. Research examining and addressing the health inequities impacting disabled people and support for efforts to include more disabled people in the research process. What I'm showing on this slide is a snapshot of the news release from the NIH about this designation, but also a headline from the Washington Post elevating that it took the disability community's pushback. We had to fight for that designation. And that's an article by Amanda Morris, who covered the disability beat at the Washington Post. But it would be foolish to ignore the current context that we are here in today. How far it seems that we've fallen from that celebration of the NIH designation. The current push and backlash against diversity, equity, and inclusion has certainly cast a very different light on efforts to make research more disability inclusive and inclusive in general. Progress has undoubtedly slowed, and in some ways, we have a backslide in these areas. What I'm showing on this slide is a snapshot of the executive order around ending racial and wasteful government DEI programs and preferencing, on top of the cover of the NIH strategic plan for diversity, equity, inclusion, and accessibility that predated that executive order. But all has not fully stopped. In 2024, the NIH began the process of developing a disability research strategic plan. This was in part sparked by the NIH designation of people with disabilities as a health disparity population, as well as based on the recommendations of an NIH advisory committee to the director, the Working Group on Persons with Disabilities, which I had the pleasure to co-chair. This strategic planning effort is ongoing and is ongoing under the current NIH director, who formed a Council of Councils Disability Research Working Group. There remains a plan to release a cross-NIH strategic plan on disability research. This elevates that this area of research, disability health research, there's still a focus. We'll certainly have to wait to know the results of this planning period and the impact of this effort. But it signals that even in this challenging time for science, including people with disabilities in research remains a highlighted issue. In part, I believe that that's because there are clear and direct lines between disability inclusive research and a much larger conversation that's happening right now about who really gets to contribute to science. The discussion that scientific knowledge alone may not be enough, and that lived experience is an equally important source of knowledge, a source that research has ignored and devalued for too long. This conversation is happening in so many places, in so many ways, all around us. This is about a shift from thinking that a visually impaired researcher is too biased to conduct vision research, to instead understanding that lived experience is deep, rich understanding of a question and should not be viewed as a challenge to science, but instead a value add that can make science so much better. So I don't have all the answers. Perhaps I have more questions. And I'll end with that thought. I am so sorry that I can't be with you for more discussion. I am certain this will be an amazing conversation and probably has been over the last 2 days. If you would like to find out more about the Disability Health Research Center, you can go to our website, disabilityhealth.jhu.edu. I want to thank everyone at the center for their work and their amazing commitment to everything that we do. I also want to share another network, the Disability Health Equity Research Network. We are over 1,300 members strong and growing. We are open to anyone, and anyone that wants to learn more about this area of work, disability health research, you're welcome to join. Thank you for allowing me to be a part of this conference and for including a discussion on disability inclusion in research.
Thank you. Okay, take two. Thanks so much. Bonnie is a hard act to follow, but I actually think it turns out it was better that way. And that was totally my fault. I apologize. That's what I get for sending slides off at 6 a.m. this morning without coffee. But what I like so much about that talk is Bonnie talked about inclusion at the end of people with disabilities. She was talking very broadly. And where I want to take us now is to kind of narrow our focus a little bit for this conference and thinking about our charge, right? So as the Sense Network, we are funded by the National Institute on Aging. So we really are focused on thinking about cognition and well-being, although of course we know that's not the end. And we want to think more broadly about that, but that is kind of part of our charge based on our funding source. So I'm going to talk about inclusion of people with sensory loss in research today. I've already talked about disclosures, so we'll skip that part. Here's the good part. Here's the acknowledgements. So as I mentioned, Sense Network, part of our goal really is to bring up the next generation of researchers. And I'm going to highlight work today that was done by some really amazing trainees, done at the time that they were trainees, and some of them are now colleagues in the room with us. So Emma Nichols, who is now at the University of Southern California, Allison Wong, who is with us today and now at the Milken Institute, and Francesca Marino, who's now doing a postdoc at Boston University. I also want to acknowledge colleagues. So Bonnie Sweenor, who we just heard from, Alden Gross and Nick Reed, both in the room. Alden and Bonnie are at Johns Hopkins. Nick just goes wherever he wants. So we welcome him every time though. And so our motivation starts all the way back when we started thinking about this work, and particularly when we're thinking about the inclusion of people with sensory loss in dementia research. We were facing a big challenge, and I still get this question whenever I give a talk, particularly to clinical audiences, right? So we know that our standard neuropsychological tests are either administered on paper, so you have to be able to see them, or they're read aloud, so you have to be able to hear it. So in order to be able to take these tests, you have to be able to see and hear the materials that we give, right? The standard materials that we have. And so the question is always, could this bias cognitive testing results? And the comment that we would often hear is, you're not testing their cognition, you're testing how well they're seeing, you're testing how well they're hearing, right? And so this really is work that Bonnie and I set out to do with other colleagues in the field to try to show that we can validly test cognition in people with hearing and vision loss. And then a result of that concern, I think, and this is standard, right? When we think about, we want to make sure that we have a valid measurement of the construct that we're trying to measure. And so oftentimes we say, this is what we have. So if you can't do it as the participant, you don't get to participate. I'm going to exclude you. And sometimes that's done in a really sneaky way. I am part of studies that use flagging systems where the individual who is administering the test makes the participant do the entire battery, but then they check a box that says those data should not be used for analysis because they don't think they could hear or see well enough. Sometimes there's also frank exclusion. I was part of a call, and this is maybe 5 or 6 years ago. There was a participant who was really interested. It wasn't even necessarily, I think the overall purpose of the study was around cardiovascular health. I'm not talking about the ERIC study. It was around cardiovascular health, but there was a cognitive testing component. And there was a man with profound hearing loss who wanted to participate. And I was part of a conversation with the investigators where they were asking me if I thought he could and should. And my answer was yes and yes. And in the end, on that call, I was overruled because he used a talk to text. He used a captioning device. And they said, that's going to change the test. He's going to cheat because he's going to be seeing the words instead of hearing them. And so he's going to be able to cheat on this test and not remember. And so he was not allowed to participate in the study. That, in my opinion, is. And we know, all of us who do cognitive testing in this room know already that it is very hard to get participants to do cognitive tests. No one likes to take cognitive tests. And already what we try to do in well-designed, well-conducted research studies is really make sure we're maximizing the opportunities for people to do well. So we already start out with that. That is always our goal. We use well-trained and certified psychometrists who are experienced with working with older adults. We often have protocols that specify testing should be conducted in a quiet room. It should be conducted face-to-face. We always encourage the use of any assistive devices, whether that's hearing aid or glasses. Now, whether the participants bring them to the study is another question, but they encourage to use it as part of the protocol. But we know there's no gold standard in terms of protocols for cognitive testing when it comes to people with sensory loss. So this was a random or a systematic review that we conducted of the literature. And what we wanted to understand is not sensory loss. That was not part of our search criteria. Instead, we just wanted to understand studies that were really focusing on cognitive testing in older adults. And they've been conducting that testing within the last 10 years. Because once we identified those studies, we sent them a questionnaire. And we asked them to either share their protocols with us if they were willing to do that, or we asked them just some standard questions like, how did you deal with hearing impairment in cognitive testing? How did you think about vision impairment in cognitive testing? And there was wide variation. So the good news is that at least 90% of studies assessed hearing or vision, but they assessed it in widely different ways. Some use screening tests, some use self-report, some you just use like the person sitting across the room from them. Do you think you can hear or see well enough? Only 22% offered accommodations for hearing loss, and only 38% offered accommodations for vision loss. So even though I think we have really well-designed standardized protocols for cognitive testing, we are not considering some really important things related to access of those testing materials. So that still is not part of the protocol. But we know we can do it. And so one of the ways we can do it is through test adaptation. Yes, that changes the test, but that also means more people can take the test. And we have some colleagues in the room who have done work on that, especially when the MoCA is involved, the Montreal Cognitive Assessment. So there's one that's been designed specifically omitting the hearing dependent items for people who have low vision, and then one that's specifically designed for people who are visually impaired. So it excludes those written pieces. Of course, that doesn't help people who have both, right? Another thing we can do is offer in multiple modalities. So this is an example of a protocol script from a test that we administer in the atherosclerosis risk community study. This is a memory test. And we start by saying, I'm going to show you some words. So we have them written large on cards that we show individuals. And then we say that I'd like you to try to remember, I will read each word first. So they see it and they hear it at the same time. We can also think about offering accommodations, so things like pocket talkers or large print. And then we can also ensure registration in the protocol. So in that same test that I just referenced, another thing that we do is say, I would like you to repeat the word I say out loud and then use it in a sentence. I want to make sure that you heard it, you registered it, it's now in your memory, right? So if we want them, if the goal is to test their memory, we've shown it to them in different ways, we've said it out loud, and we've made sure that they've heard it because we've asked them to use it in a sentence. Another protocol that we have developed is something that we call ensuring speech understanding. This is a protocol that we administer before cognitive testing for everyone in the ERIC cohort, as well as in the ACHIEVE cohort. And so that's our randomized controlled trial that looked at the effect of hearing rehabilitation versus a health education control on cognitive decline. And so what we do here is just read some simple sentences. There are 3 key words in each sentence. We want to make sure that people are able to hear those sentences and say them out loud to us. If they cannot do, even after we've repeated and made it a higher volume, we still go ahead and record that testing. We just note that there may be some concerns with hearing as well. So this is a protocol that we've developed. It's published out there. It's available in the literature. And then something else that we can do is actually test for bias using statistical methods. And so this is work that Emma Nichols led with Dr. Alden Gross on assessing bias in cognitive testing for older adults with sensory impairment. She used data from the Atherosclerosis Risk and Community Study, as well as the Baltimore Longitudinal Study on Aging. And the methods that she used were item response theory methods. And so it really is a simple question, right? So the test should measure cognition the same way, regardless of whether or not you have hearing loss, regardless of whether or not you have vision loss. And so that's what these methods try to determine, right? So the question that these methods answer is, are the scores on tests that depend on hearing different among those with hearing impairment controlling for underlying cognition? So if you have the same level of cognition, you should be scoring the same way, regardless of whether or not you have hearing loss or vision loss. And I think there is actually a lot more work to do in this area. There's only been a handful of studies. And I think Emma has been involved in all of them. But what I will say, at least from this initial study, is that we didn't see any differences. The diff is differential item functioning. So there were no clinically meaningful differences there. There were some. And so again, I think we have more work to do here. But there weren't any that really should make a difference. Now, I will say these are 2, again, really well-designed, well-conducted research studies. If we're talking about in a clinic space or in a different space where their protocols may not be the same, it may not be a quiet room, it may not be face-to-face, then I think we could potentially, obviously, expect different results. And I think then that also leads to broader consequences. So we start thinking about, okay, I've developed this test or I have this test or I have this intervention, developed this intervention. Now what do I do with people who have sensory loss? And so this is work that was led by Francesco Marina and Allison Wong, where they looked at how people in cognitive training interventions, so these were RCTs of cognitive training, how people with sensory loss were handled, right? And so this is just taken directly from their conclusions of their abstract. Older adults with hearing and vision impairment are underrepresented in cognitive training interventions. Why are they underrepresented? Because they're excluded if they show up, or they're not invited to participate, right? Reporting of hearing and vision measurement, proper justification of exclusions, and inclusion of accessibility and universal intervention design are also lacking. These findings raise concern about whether current trial findings apply to those with hearing and vision impairment, which we know is the majority of our population of older adults, and whether they generalize to the broader population. It is critical to include more diverse study populations and integrate accessibility into intervention design to include and better represent older adults with hearing and vision impairment. And so yesterday we started this whole conference off by talking about that 2017 white paper. And so where have we made progress in this space around inclusion since then? So the 2 big questions, and these are direct quotes pulled from that paper related to measurement, were how can we develop and implement standardized protocols to measure cognition in older adults while taking into account visual impairment, hearing impairment, or both, in clinical and research settings? And how can people with severe sensory impairment be included in studies that measure cognitive function? So how far have we come? Last time, yesterday, we were talking about maybe like 50%. I don't think we're anywhere near 50% on these questions. I think we have so much more to do here. We tend to be trained so much to think about the importance of the measurement properties that we forget that when we really abide by those, we are naturally selecting a very, very small proportion of the population. And that's not really who we want to make inferences to. And that excludes people that we need to have included because we need to understand how to treat them. We need to understand these results so we can inform clinical decision-making and policy decision-making too. So I will just kind of wrap up with a couple of thoughts for conversation. And I hope, obviously we can have some conversation at the end of the session today, but I hope that you also take this back to your working groups this afternoon. We know that measurement is so important. And I'm not meaning to say measurement isn't important. We can't use a test that's not valid or not reliable, right? We have to have that too. But I think we often prioritize that by default because this is the measure I have on hand. And instead of viewing it as our charge to adapt that measure to make sure we are accessible and equitable in who can participate, we simply say, you can't do this test, so you don't get to join. And we may not say it that way, but that's exactly what we're doing when we exclude people from participating. Exclusion, I think, is very inequitable. It ignores the majority of older adults. I do want to say, and of course, absolutely, in our studies, it always comes down to the research question. So of course, there may be some times where we really do need those exclusion criteria. So I don't want to be completely black and white on this issue. The research question is incredibly important. But just something for us to consider, because I think the problem is now we don't even really start to consider it. We just start with the measures at hand. The other thing that I would just like to say and get us thinking about is universal design. So there's lots of universal design principles that I think we have now been very good about starting to implement in other aspects of our work. So for example, with teaching, but that has not made it to the research space yet. And so I think there's a lot of room here. And when we start asking people to self-identify or self-select, that in itself can be another barrier. So if we just have accommodations that are available for everyone so that you don't have to ask, I would argue that that really helps everyone and also encourages participation. So that is my last slide. I will end there. And thank you for your time. And I think at this point, then we can go ahead and move on to our next speaker, who is Dr. Kathy Pekara-Fuller, who will be joining us online. So should I stop sharing here? Okay. Thank you. Thank you.
Okay to start?
Yes, Kathy, thank you. Welcome.
So tell me when you want to start.
Kathy,
Can you hear me?
Not sure we're muted.
I can hear you. Can you hear me?
Oh yeah, we hear you great. Feel free to.
Shall I just start?
Yep, thank you so much. Thank you.
Okay, here we go. So I'm sorry I'm not there in person, but I'm very happy that I can share this online. And I am a professor of psychology and also gerontology. But today I'm going to focus a little bit more on my roles as a board member in a nonprofit seniors group called Seniors Keeping Young. So very local, and also some of the experiences I've had working with the WHO World Hearing Forum as a representative of International Collegium of Rehabilitation Audiology. So I'm going to go kind of local to global. And follow, I think, nicely from what we have just heard from the last two presenters. So we are in the middle of the UN Decade of Healthy Aging. And I think, why are we here? We want to change the lives of our neighbors, our patients, of individuals. We want to change how we deliver clinical services. We want to change the world that we live in so that it is a better place for older adults. And according to this idea of healthy aging, it is about creating the environments and opportunities that enable people to be and do what they value throughout their lives. So I think that is something we need to keep front and center. And in order to kind of move us along in this direction, the WHO back in 2017 created some guidance on the integrated care of older people. And there was a very recent second edition of this. So I hope everybody who doesn't already know it goes and looks it up. And basically, this care of older people is integrated because somebody says, oh, I work with people with dementia and you work with people with hearing loss. And I say, no, it's the same people, because various things may decline as people get older, including vision and hearing and cognition, also mobility, psychological health, and vitality. So these complexities increase with age, and we're more likely to have converging declines that may affect everyday functioning. We want to get at these problems early so that people can continue to function well and avoid becoming dependent in the healthcare system. We want to address the priority conditions of the individual. We need to screen and assess both the health and the social needs. And this idea of person-centered primary care is kind of a new world that we need to venture into. And hearing and vision have been largely excluded from primary care, and we need to find a way to incorporate them, because there is nothing that you will do in the healthcare system or in your life, or there's very little that you can do without sensory input of some kind. So this is ultimately going to take us into the lives of people. And I've learned so much now working in this seniors group that I never learned in the clinic and I never learned in the lab. So this graph is sort of the foundation of what I think makes sense to me as a rehabilitationist. So what the graph is showing is that over time, there are declines in various intrinsic capacities. The red line is going down. But as rehabilitationists, we can push up functioning despite the declines that people are experiencing. So it's not that they have declines or that they have disabilities, it's how do they live with them? And this is a clinical necessity. So the era of the healthcare systems being strictly for physicians and not for rehabilitationists is something that the WHO would like to see changed across member states. How would this work? They've given us a lot of details. Inside the World Hearing Forum, we've developed the World Hearing Report, we've developed guidelines for screening. There are tools for screening hearing that are appropriate for countries around the world, even low-income countries. There are equivalents in vision. The guidance is that older adults 50 years and over, in the context of their regular checks, should be screened for hearing. If we got it this early, we wouldn't have the dilemma of trying to figure out what somebody's hearing and vision is like after they're already in long-term care. We would nip it in the bud. So let's think about doing this in late middle age. This study in France was using this ICOPE procedure, and they, based on the screening tools available that are outlined in ICOPE, identified that in this multi-domain Alzheimer's prevention trial in France, actually more than half of the people had hearing loss. So that would have gone undetected if we weren't using this integrated approach. And I'm happy to say, and these are Canadian colleagues, but I'm sure there are many other examples. I hope there are many other examples that we now have the recommendations for the management of dementia in primary care that the geriatricians have developed in Canada, saying that hearing is part of that guidance. We have Manuel Montero Dasso is another Canadian who's developed the world guidelines for falls prevention, and it includes information about the importance of hearing. So we have this crossover where hearing and vision are being integrated into the work of other people that, up until now haven't been in the conversation. This was a recent ad for a sarcopenia conference, actually in Johns Hopkins, and it is asking for people papers in sensory function. So who of you is going to that? Because these are other researchers who want to know about sensory function, and we need to connect with them. So we have many, many new partners that we have to extend our work to. And this kind of makes sense because if people are living their everyday lives, they do use hearing and vision and other senses and their motor abilities. And the brain kind of creates the priorities that are important for acting out normal everyday activities like crossing the road and having a conversation and remembering the gossip so you can tell it later. So we cannot live our lives without integrating these things. So why isn't our care and our research also integrating them? We had a little mention yesterday about self-report versus behavioral measures or objective measures if we get into brain measures. And I just want to share this because it really taught us a lesson when we were looking at the Canadian longitudinal study on aging. So the vertical are pure tone average numbers. The colors indicate degrees of hearing loss. We have females on the left and males on the right. And we see that, in general, the median values are progressing as expected, but that there is huge variation. So people who audiometrically would classify as being normal could say in their self-report that their hearing is excellent, very good, good, fair, or poor. Any one of those is a possible answer. And of people who have moderate hearing loss, we also have people who sometimes say that they have excellent hearing. So this is about their impression of how hearing affects their everyday life. So we really need to capture that and be a little bit more savvy about it. I'm going to take you into my everyday life. This is the ferry arriving on my island of 4,000 people on the west coast of Canada. This is the Seniors Keeping Young group. So there are 50% of the island are people 50 years and older. This group has been around for 30 years. And they are meeting here near the ferry dock. The building beside them in the lower picture is the library and the art gallery in town. So that is their life. That is where they live. That is where they need their hearing, their vision, their cognition, their mobility. That's where they eat. That's where they exercise. And what do they know about research? So recently we got a knowledge mobilization grant for the voluntary sector. So Sky got this to learn about how to promote healthy aging and brain health, and basically learned the knowledge that we've gained in the Canadian Consortium on Neurodegeneration and Aging and some of our work on the CLSA. So in our community center, so this is not in a university, it is not in a clinic, this is like out there in the community. We have an accessible space in our small theater. The theater takes about 150 people. We typically have well over 50 attending. We have a full-size screen. we have captioning, we have microphones, we have room systems. People are so happy that they can actually communicate in this space, and they have been very hungry to learn about the research we're doing. And many of these people are over 80. In the audience are people from our new integrated community health center. So this is a living example of this implementation of integrated primary care. We have people from our men's shed. If you haven't heard about that, you have to look it up. It's a big international movement to promote social well-being amongst men who have otherwise often not participated in health promoting efforts. We work with our library. So this is a community effort. Our municipal councilors, our health providers, they are in the audience too, and they're listening and they're learning, and we're all interacting. Soon we will be starting with that community cooperation assessment of how to implement the Brain Health Pro program that we developed in CCNA. And that program, it includes hearing and vision, but it also includes, and what about your sleep? And what about your cognitive engagement? And what about your social engagement? And what about your vascular health? And what about your physical health? So a lot of the conversations we've been having in those sessions in our community is the importance of physical exercise for brain health. That's the best evidence that we have, is for physical activity as an intervention. But actually, you need to hear and see, you need that accessibility, that universal design, in order to make the most advantage of it. So the accessibility kind of format that we have gone over, this is a lot of work with my CCNA colleagues, especially Walter Wittich. For the World Alzheimer's Report, for Brain Health Pro, we use this rehabilitative trio of what can we do with technology? What can we do in the environment? Think room acoustics, think lighting. What can we do to change attitudes and behaviors? And all of this is very practical and applicable to everyday life. And we do not know what in everyday life, do people want to apply this approach to. After one of the sessions, one of the members of Sky sent me an email saying that she's part of the Island Death Care Collective, and that they hold educational events such as death cafes. And people she knows are struggling to hear in small groups in a large room. And how can we mitigate this? How can we implement some hearing accessibility? I never would have thought of that important application, but it's coming from the people who are older. So they need to be our partners, and we need to understand what in their life our knowledge may be useful for. The good news is that at the global level, the World Health Organization, this is also the decade of rehabilitation, and hearing is in the picture. We have a working group on primary care, and audiology is part of that conversation. So hopefully we're going in the right direction. Optometry is also part of this picture. These are the rehabilitationists that are the logical partners for hearing and vision. In Canada, we have Team Primary Care. This is an initiative sponsored by the federal government and by the Foundation for Family Physicians. And we have spoken a lot about how to change training of health professionals and to use this interprofessional team approach. The Speech Language Audiology Canada has made available to its members the toolkit for entering into this way of thinking about doing our work. So lots of material on that website if you look up Team Primary Care. So we are putting this together in our research. The people who are going to benefit for our research may be living in the real world, may be coming to the real healthcare system, not just to us, but to other health professionals. And we need to kind of put it together. So this is an artist's view of our new Island Community Center. And from the beginning of the design, we've tried to consider accessibility, not just in terms of technology, but also in terms of environment, behaviors, and attitudes. So I think these are the kinds of products that ultimately our research has to lead us to. Thank you.
Thank you so much, Kathy. That was amazing. And so our final speaker of the morning is Dr. Nicholas Reed.
I hate phone. Well, you did. Yes. If I stand back here, is it still audible? Like it's picking me up? I think so. I hate following Kathy because she's doing more in retirement than I'll ever do in my life. So I'm going to bring probably more of like a broad picture on policy through the narrow lens of what's happened in, I think, hearing care in the US over the past decade now. And hopefully it sparks good conversation. So I'll try to make sure I end on to get us back sort of on time so we have plenty of time for conversation as a group. I think when talking policy, it's sort of important we sort of go back and think frameworks and where do academics fit in? And I like, this is actually a figure from Dr. Sklow's book, Beyond the Basics, on epidemiology Beyond the Basics. Jennifer is actually the one who brought it to my attention. I hadn't seen the figure before, but it's a good way of thinking about where do we fit in the academic research process to getting to policy. And the truth is, if you were to circle where we are in sensory work and where policy has gone, sensory is probably still at sort of number 1 or number 2, and we've jumped to 5 on policy. And what I mean by that is when you think policy, you have to remember that it happens sort of from individual perspectives. Freakonomics is the book that sort of made us all aware of some of this, but we think of policy as all this wonderful evidence, and the Office of Budget Management in Congress sits and reviews everything. The truth is most policy are just individual stories that eventually make it onto the big stage. Freakonomics points out that all the seatbelt laws in the United States are not based on a single piece of scientific research or evidence. They're based off of 9 families telling their very tragic stories before Congress. And as we should have those laws, they're not bad. There's no downside. I'm not saying they're bad, but it is an insight into how these things happen. And so policy is individual level going out often, but those big picture aspects and evaluating the policy dictate individual level it's in itself. So there is sort of this push-pull direction to it. In our field, hearing has hit this sort of stage where this is the Lancet Commission on Dementia model. We're looking at, well, this is actually, I think, the 2021. There's a 2024 one now that does include vision now. But you essentially, if you were to interpret this 8%, what they're saying is that if you eliminated all hearing loss in the world, you would eliminate 8% of dementia. Most politicians and policymakers have interpreted this wrongly to think that, well, at even an individual level, hearing loss is the largest risk factor for dementia. It's not really true. It's more of a population model. But regardless, we've hit this, and we've gotten this recommendations everywhere from New York Times, Washington Post, the CDC saying get hearing aids. It will eliminate dementia. It will do something. We jumped so far ahead in our model where we had really just started here and said, okay, we think these are related. We think there's pathways. We think this is real, to do something, right? Put a hearing aid on here. When we actually started to look at this, though, the ACHIEVE work tells us, unfortunately, in a large randomized control trial, we shouldn't overstate the results. The main part is null, right? 900 and almost 1,000 people, let's say, 980,000 people, randomized control trial, best practice hearing care over 3 years, looking at cognitive decline. And the overall trial is null. There's no difference in those who received hearing care and didn't receive hearing care. But in a sub-cohort study, where we looked at people who were recruited out of different populations, we do see that those who came from the ERIC study, they've been in an epidemiologic trial for 30 years, we see a 48% reduction in cognitive decline. Our team asks why and who, and we think that it's mostly because the de novo cohort are extremely healthy volunteers. And if you think about dementia research, the healthy volunteer effect is real. The first thing that John King from the NIA stood up and said at AAIC, where we unveiled the results for the first time, was, who joins dementia trials? People who are never going to get dementia. And he's right. And so I think that there's some signal here, but the overall results are null. And when this is interpreted into a policy lens, actually, we're so bad at messaging, despite sometimes the way we sort of do things, where we have some team members talking about this study as sort of this is the finding, the 48% reduction, right? This is what's on the cover of Lancet. But the OMB did actually review the study, and then that went to NAPA, the National Action Plan on Alzheimer's in the United States, and they lowered hearing loss as a risk tier for dementia because they saw the overall null. And so I do think that when we think policy, it's important that we do something because message correctly and sort of start to control our sensory messaging, because policy moves in parallel to what we do in the clinic and in our research. In the US, hearing aid use adoption. So this is data from a national study, NHANES, National Health Examination Nutrition Study. If we look at those with hearing loss 50 years and older, and we look at not just hearing aid ownership, but also saying they use hearing aids, it's as low as 16%. And that number is incongruent with sales figures, which would tell us it's probably closer to 30%, which says a lot when you put use in there, right? I think in the auditory world, those of us who are clinicians will say these are ITD hearing aids. They're in the drawer hearing aids. No one's touching. But I actually think the story is worse. This is data that our team produced in JAMA Internal Medicine a few years ago, looking at from 2011 to 2018, hearing aid adoption trends among adults 70 years and older. Nationally, we see a 23% increase in hearing aid adoption. But if you start to look at who is adopting hearing aids, white males are a 28% increase, Black females are only a 6%. If you look by federal poverty income ratio levels adjusted for wealth for this group, those below federal poverty income levels see a 13% decrease. We stopped at 200% or more. Usually we see 400% or more. We just stopped at 200 because we saw a 30% increase in that group. It's largely driven by haves and have-nots. Why this should worry you, though, from a policy perspective, is what happens from 2011 to 2018. The ACA, the Affordable Care Act, goes into place. The largest expansion of healthcare access for low-income Americans in the history of this country happens during this period. And we go from around 6 to 28 states covering hearing care on Medicaid, low-income insurance in the United States. And we see an overall decrease. Just by sheer numbers alone of coverage access, we should have seen an increase. And we see a decrease. So I think whatever we think about the research we do from a policy perspective, we are failing people in many ways. I think that when we approach this, even if hearing care does not impact the outcomes on cognitive decline and dementia, they do get a lot of attention, they bring us in the door, but we still should be thinking about affordable, accessible, and appropriate hearing care. And I make this statement for this group because the Sense Network is based off of cognition, right? We think about sense and cognition, but if we're going to do policy, we have to think broader and bigger picture, and we have to approach this with a lens that we have a goal of affecting people in the end. The policy and public health timeline, in 2011, we start to get the publications putting us back into the mainstream. A lot has happened since then in policy for hearing care. In 2015, the President's Council of Advisors on Science and Technology met for the every other year. The White House used to do a conference on aging. We didn't have one from 2016 to 2020. Don't know why. And then we haven't had one. We're probably not going to have one again for 4 years. Don't know why. But this used to set the agenda for aging policy in the US. This is where Social Security was born, right? So the entire Medicare, Social Security Administration Act for Medicare is born out of this conference. And it used to happen every other year unless we were in war in the US. They tier out issues facing older adults, and hearing loss was moved to tier 1. I don't know if anyone in the room knows why, but again, personal connections matter. Michelle Obama's father got hearing aids, and the Obamas moved it to tier 1. So it literally is a personal connection piece. And they examined hearing care in the US. They wanted to know why it was so expensive. And basically, they came out with a recommendation with PCAST saying we need to figure out a way to change the market and get more competition in and sort of lower costs of hearing aids. They saw that 5 companies owned 99% of the hearing care market and wanted to change that. That starts to trigger the National Academies of Science, Engineering, and Medicine, sort of at the same time this is going on. They trigger a report, a consensus report on aging and hearing loss in the US, which makes a direct recommendation for over-the-counter hearing aids. That triggers an immediate push and introduction of an over-the-counter hearing aid bill in Congress. And then in 2017, we get that bill attached to the FDA Reauthorization Act, and it does pass. What's sort of, I think, not talked about enough, though, is that this wasn't just academics. The face of this were several academics, but that was a choice. Bose, Elizabeth Warren's district, was making a hearing aid, and they wanted to break into the market. And I think this is where our lesson is. We are academics, and we do a good job of looking clean and talking about all the research and sort of presenting the policy. But the truth is, behind the scenes, we need to partner with industry to make market shaping solutions. Without Bose, this doesn't go forward at all, right? And Bose actually sort of had this behind the scenes deep conversation on whether Frank Lynn should be the person testifying. And I wish he was here to really talk about these insights. This doesn't mean that Frank wasn't pushing this. He had his own ideas at the same time. He was writing about this, but they very much saw an alignment, and it became a win-win sort of rise all tides situation. And they pull in academics and they pushed forward. It was even better because in this case, they were able to pull together a rare thing that probably isn't going to happen again. This might even be the last good example of Republican and Democrats working together on this, because they were able to see it as increasing access from the Democrat side and then market competition from the Republican side. We don't see that very often anymore. At the same time, from an academic perspective, we had to provide some sort of guidance. The bill was introduced in the prior Congress before it was finally passed. And one of the big issues was they flat out said, hey, there's no evidence to really say that these over-the-counter devices could be as good. This is actually my first author publication. It was in JAMA because I'm that awesome. We actually just said, hey, and the truth is, the impetus for this and why I joined Franklin's lab was I was giving out over-the-counter devices at Georgetown University Hospital in the clinic because I kept seeing people who couldn't afford devices. So it was how I got pulled into this. And we did a study with 42 older adults with hearing loss, and we started a round robin where we used over-the-counter devices against a traditional hearing aid. Very controlled study, right? Very well controlled. We're just looking at these individuals and letting them use different devices. And you get almost the same results with $350 devices as you do with a $2,000 device. But this was needed, and it became literally Exhibit A at the Senate congressional testimony for the bill when it became part of the FDA Reauthorization Act, because there was no academic insight to really support this. There were these big picture ideas and economics, but we were able to offer something meaningful. And I think it's part of this being responsive. And so we do get this market shaping solution concept for over-the-counter hearing aids that I sort of give this as where we should be thinking as academics when we think about, okay, we want something, right? We want more funding, we want better access, we want more coverage. How does everybody get a win? And this creates the Over-the-Counter Hearing Aid Act was meant to create market competition, increasing affordability, new companies could get involved. Part of the problem is that there's a lot of vertical integration into hearing care in the US and around the world. It's very hard for a new company to get in. I don't think Vision is very different. Olfaction's slightly different because I don't think they have the same sort of clinical infrastructure facing patients at the moment, but I'm sure it's not that different because vertical integration seems to be a factor of healthcare in general. Separating providers from the device, so actually getting rid of a gatekeeping model in some sense, connecting the end users to the manufacturers, And then these new market entrants also creating public health awareness was a big part of it. And I think some of this has happened. I think the bill itself, I'll say in a minute, has sort of had its own issues. But if you see Apple, who has created a hearing aid, and Apple has a commercial now, you do see sort of mainstream concepts of hearing loss coming around. And so it sort of moves us from my screen, this screen is like super delayed relative to this screen. So it moves us from sort of this gold standard to, give it a minute, there we go, a hybrid and consumer directed model in the pyramid, right? And so we actually have different entry points for different people, right? So you could have pure, give it even more time, pure sort of self-driven models to hybrid clinical models to that traditional gold standard all working together. And right now we only had that gold standard. And so when we go back to our timeline, in between waiting for the OTC Act to actually go into effect and achieve sort of happening, we had Build Back Better. There's a really long delay. So on my end, if I'm pausing, it's because I'm just waiting. So the Build Back Better goes into effect. And with Build Back Better, the impetus is this, where again, researchers can make a huge difference. I still can't believe in some ways this happened to me, but it's the coolest thing that ever happened to me was I got a call straight from Bernie Sanders' office to come to the Senate Finance Committee. And he came in and he is as gruff as you think he is. And he literally slapped down this paper and one of my other papers and said, we need this for Medicare expansion on hearing care. The point really is that this is all driven from a research model saying, stop worrying about devices and think more about the services side, right? It was something that, the economic modeling is all device, 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 and that's not what people receive, right? And so this is a clinician scientist insight piece where we should be focusing on services to help people, but also writing pieces like this that he put in front of us where we outlined, and this is what I think our policy group is starting to think about here today, what are the changes needed? Because one of the problems is for Medicare, hearing care is a statutory exclusion. We need an act of Congress. We're also not set up to actually capture any of this information or deliver hearing care under Medicare. Basically, we have a bundled model where everything revolves around the device right now. So we needed to move away from that and start to separate and decouple services from product. Start to think about hearing care based on degree of loss, but we don't have ICD codes to actually indicate degree of loss. Even with ICD-10 that has sort of the severity indicators, there are no severity indicators for hearing loss, meaning that we're treating mild loss the same as severe loss, even though they are extremely different circumstances. And I believe it sounds like this is the same for olfaction, and vision even has some similar problems, right? And so I think there's an infrastructure part that we should be thinking about up front, because oftentimes academics are sitting on their back heel kind of waiting for things and then saying, oh, here's all my ideas. But I think we can be more proactive on this. And so with Build Back Better, we actually got it into the final bill. This was what I spent my entire summer in 2021 doing with the Senate Finance Committee. For those of you who know, it failed by 1 vote. For those of you who really know the story, with Joe Manchin voting against it, a senator from West Virginia's second largest donor that quarter was Starkey Hearing Industries in Minnesota. So to give you an idea of how unpopular this was with industry, someone from West Virginia was getting a lot of money from Minnesota, and the deciding no vote. I'm not saying he only voted no because Build Back Better is a huge bill, but I'm certain that this had something to do with it. You can always follow the money in politics. So ultimately fails, but just for a win, this was the first time hearing care was voted on actually in Congress since 1965. It's been introduced in every single Congress and committee and never made it out of committee before. We did finally get the FDA final regulations, and they kind of changed the impetus for what over-the-counter hearing care was supposed to be. And they gave it a 510K exemption, meaning that you just register with the FDA. You don't have to provide clinical trial evidence. And so instead of receiving sort of 5 or 6 really strong consumer-driven market entrants, we end up with now, I think they're over like 9,000 registrants, mostly in China and India, globally, with the FDA saying that they are over-the-counter hearing aids. So it's just sort of a set of criteria you, on a handshake, say you meet. When you're 510K exempt, you're registering with the FDA. You're not really approved by the FDA. And I do think that from a research perspective, this is a problem. I think one healthy thing that we should be able to do is say, yes, many of us championed OTC hearing aids, and now it's been, in some sense, bastardized and changed. And it's not the same thing we might have wanted. We may have wanted, maybe it's going to show. Okay. We may have wanted something that had a direct consumer and a traditional model. In the traditional model, the consumer is protected by the audiologist, right? The gatekeeping model actually protects them. The audiologist is not going to sell them a piece of junk because their license, their warranties, it's all on the line. When you do 510K exemption, we're relying on the FDA to protect the consumer. And we don't have that. The consumer is basically given no sort of protection. They could buy a $250 device that is registered with the FDA. People do not know the difference between registered and approved by the FDA. They don't know what that means. And we lose those people to future hearing care. And I will actually use a real example. Again, politics are individual. My great uncle, Bob Jett in West Virginia, Vietnam vet, has hearing loss, and most vets do. This is someone related to me, knows what I do. Didn't call me, didn't want to talk, said he got a hearing aid on Amazon. It didn't work. It was a $100 piece of junk. And then he told me that everything I do is probably made up and phony. So it's true, though. We've lost him to hearing care. And this is my relative. This is someone I could have got free hearing aids probably for and didn't want them, and we've lost them. And I think that story, as funny as it is, it's true of what's going on in the United States when we have bad policies like this that get enacted one way, no matter how positive or how hopeful we were when they were enacted. And I think this is where it's our responsibility. And I sort of think groups like this are in a prime position to do this to, again, I think many people in the room, and myself included, were champions of this, many people in the broader spectrum, but we have to go back and say now, hey, what has happened isn't what should have happened, and we should be sort of revisiting this and continuing to put pressure on improving the lives for consumers. And so I think we're sitting sort of here with just some evidence, and Achieve has happened. Perhaps it has market shaping implications, but the truth is there's so much more research to do, because Achieve is this. It is gold standard audiology on steroids. 4 audiologists, each with 125 people caseload over 3 years with no other caseloads. That is not reality, right? Clinical trials are, by definition, efficacy research, right? This is not implementation work. This is not effectiveness. This is not a pragmatic trial. That means that there is so much work to do on explaining the rest of the models out there. Because sure, we've learned a little bit about this one. My God, it is so hard to do this with the delay. But we know nothing about the other group. I put in way too many transitions. So I think when we're talking in our groups, we should be thinking more about a central think tank that's sensory related working together. We lack a singular or authoritative voice. I will use the dental groups as an example. If you know anything about the ADA, they've set up their own think tank that is a 501c3 nonprofit. And they do a real good job of manipulating the policy. They do a really good job of putting out pieces that say, this is the minimum we should accept, and this is the maximum we should accept. And we know that they want something in the middle. And I'm not saying that manipulating politics is the right thing to do, but I am saying that is the game. And that is where we have to think about our research and how we fit into it. They're not necessarily being nefarious either. They're just saying sort of, here are 2 sides, and they know what they want in the middle, but they're setting the groundwork for it so that they often get exactly what they want. We don't have that at all. And I think that hearing doesn't have it. Vision actually does have a few think tanks out there thinking policy. Olfaction doesn't have it. Proprioception doesn't have it. Balance, we don't have it. We could be thinking more of a sensory-based group. There's no plan or preparation to take advantage of the moment when it happens. It should not have been me alone sitting there at the Senate Finance Committee against 5 manufacturers and having these conversations. And I'm not saying that as some sort of martyr sort of thing, but I'm just saying I'm not the guy to do it and shouldn't have been the guy to do it. I just happened to be the one tapped. We should have had a bigger group, and there was no one for me to really go to bring in. We don't know what we want right now without these think tanks because we're not set up to do it at all. So I think these are some things to think about when we go back into our groups. With that, thanks.